That's great. All right. Thank you all for coming. I want to welcome you to the NUCare and PHI seminar for this week. And it is our great privilege to have Professor Vespignani, who's the Sternberg Family Distinguished University Professor in the Department of Physics, the College of Science here at Northeastern, as well as with interdisciplinary appointments in the College of Computer and Information Science and the Bouvet College of Health Science. Professor Vespignani's research activity focuses on the interdisciplinary application of statistical and numerical simulation methods in the study of biological, social, and technological networks. He serves in the editorial board of several journals and is the editor-in-chief of EPJ Data Science, which is published by Springer. He is also president-elect of the Complex Systems Society and on the board of the Institute of Scientific Interchange, and we are very grateful to have him here to talk with us today.
Thank you very much. Just two questions for you. Are you recording with this one, or?
I believe both are recording.
Okay, because probably this should be moved around here, because if you don't mind, because there you don't get,
this here?
you don't pick up, no, this one.
Okay,
Oh,
sure, that should be fine.
Yeah, and then I'm sorry about that, but this apparently is the recording system for the screen. Not sure if we can take it out or not. No, there is no, so
oh, there's
leave
no
it
person.
there.
Okay,
So we will
sorry.
survive, I'm sure. So thank you very much for the invitation. I'm very glad, and I will talk about computational epidemic modeling. I will probably go in direction that are not usual for this seminar. So I will not focus too much on the single individual or a specific device or technology, whatever. I will look more at a public health perspective on a large, very large scale. And part of the work that I will present is recent work about the Ebola epidemics that I will use as a kind of case study for my how to say, take-home messages. And this is something that has been done in collaboration with several people, but mostly under the umbrella of the Center for Inference and Dynamics of Infectious Diseases, that is an excellent center of NIH under the MIDAS initiative and the Defense Threat Reduction Agency. However, what I will show you is something that has started more than 10 years ago now, and probably, you know, there have been about 20 to 30 people who have collaborated actively on results and tools and approaches that I will discuss today. So let me start from here. So we're all used to the fact that you go on a web page and you know the weather for the next 10 days. You also know by experience that for the next couple of days those forecasts are pretty good. You're also very used to the fact that there is probability and you have 20% chance rain, so we are all familiar with that. You also know that after 10 days, those predictions are generally not reliable, and you don't give too much attention. And so, you know, this is something. Weather forecast is a program that started, you know, a long time ago through really visionary people that started to do crazy things, like Richardson in 1920. That he took those kind of equations and he did the integration by hand. He took more than 20 days to do a few hours forecast. And so this is total craziness, as you can imagine. The poor guy, unfortunately, then compared with historical results of the forecast, and the forecasts were wrong. And actually, they were not wrong because of the methodology. It was wrong because he did really factual error in the computation, just that, you know. And he calculated that there was the need to do some kind of real-time forecast. At the time would have been necessary 60,000 people working at the same time, you know, doing those calculations. Well, what happens in epidemic forecast in infectious diseases? Well, around the same years, Reed Frost defines a model that is a stochastic model of epidemics. Is the simplest chain binomial process you can imagine. And actually did the integration of the stochastic part, since computers were not there, on what I call, you know, the sandbox computer. So it was having two jars with peoples, and he was extracting little balls randomly. Those balls had colors that meant if the person were going to be infected or not in a total random process. So you see, the things were more or less in the same situation. Then in 1950, the first numerical weather forecast, a 24-hour computation made on a computer, was pulled off. And then you see, this is a 24-hour computation for a 24-hour forecast, so totally useless. But you see, okay, it can be done. And that was a big result. At the same time, 1952, the first leap frost numerical implementation. So you see, things were going side by side until in 1955, basically numerical weather prediction model becomes operationally in the United States. A national weather forecast center is put in place. And in 2015, we have that this is just regular business. Instead, basically, we need to wait until 2000 to get some more progress into the modeling of epidemics. And 2005, large-scale region-based model. 2015 is the story that I will tell you. But obviously, a gap of 15 years has opened in these two things. And this gap is not just for public health or infectious diseases, but for many other things involving social systems. And so that was weather forecast in 1955. Not so nice as you see now on the news, but that's it, it's there. Well, let me do a little digression. There are many ways we can do forecasts. And probably that you can take a signal in time and do a lot of statistics and do forecast. That you do with linear regression method, SB machine, whatever, machine learning. You can do all those kind of sophisticated linear and nonlinear analysis of a time series and get nice results for the next couple of points of the time series. Well, this is not what I'm talking about. Why? Because this is like, if I tell you that weather forecast, well, let me give you the simplest example of that. I record the temperature in Boston for a couple of years. And then you will see the plots. And you know that in the summer, it's very hot. In the winter, it's very cold. And if I ask you, what will happen in the next winter? Will you be able to answer or not? Yes, more or less you would say it will be cold. Okay, we know that on average the temperature will be like that. Well, this is what statistical methods does. Pattern recognition, very sophisticated pattern recognition, but it's the same pattern recognition that we do when you say about summer, spring, fall, etc., etc. This is, however, is completely agnostic to what is the time series. If you have a pattern in that time series, you can start to do forecasts. If this is the stock market, you don't care. You can do forecasts with the same exact techniques. If it's anything else, you can do that. Okay? And then, actually, I'm not downgrading those kind of things. This is the frontier as well. For instance, Google Flu Trend has been a good example. You can look at the search of people on the web, and from there you know what is the incidence of flu in the United States. Well, actually, it's not that simple. They were wrong. They shut it down a few months ago. But this is the thing. You can look at Twitter messages and get a good approximation of the time series of the flu. Again, you have to be very careful because if you use Twitter that talks about zombies, you get the same results. And so this is a little, there are some issues. But given all these caveats, this is interesting techniques. But there is something that is very different from the weather forecast as we intend now. So this is now the weather forecast that we intend. So this is a hurricane, and we want to project the path. To do that, you need to have an understanding of the physics, of the atmospheric processes. You need to understand the laws for the movement of aerial masses, the sea surface of the temperature, etc., etc. And then you have generative models that doesn't just give you the next couple of points, but they really project the path of the hurricane because of the underlying understanding of the system. And this is what we would like to do with infectious diseases. Now, why that 50 years gap? Well, the 50 years gap is because we put satellite in orbit. We built, thousands of weather stations across the world. We enabled those stations to share data in real time, high quality real data. We set up supercomputers with algorithms that were, running different models. You see, each one of these different colors are different models. So that you know that more or less if the models agrees, it's a good story. When they start to open up too much, like here, then, well, let's reevaluate the situation in 3 or 4 days. So all that has not been done in infectious diseases, as well as in many, I would say, systems where there is a big social component, because we didn't have the data about us. That is the major issue. That was the real hurdle. Now, if you think about models and go into the same approach of the aggregate for the infectious diseases, you get what we call micro-individual, large-scale computational approach. What does it mean? That these are models that takes each individual in a population as a single and discrete entity. For somebody who is expert on differential equations, homogeneous mixing, etc., this is not the way to go. These are, rough approximation. Now we have to introduce all the heterogeneities of the real world. And the heterogeneities of the real world is our behavior, is how we commute, how we travel, how we go from one place to another, how there are different populations density in a country, and so on and so forth. There are different techniques that you can use in terms of models, and there are different ways of approaching the problem, from the very single individuals and the construction of accurate household structure, etc., to something that is more coarse-grained, but perhaps more global range, etc. This is not important, but these are always models which are data hungry. So they really need a lot of data to be fed, and if you want to have something that is not, how to say, trash in, trash out, you really need to carefully screen out those data, understand what kind of data you need to answer a specific question, and so on and so forth. There are obviously differences with respect to weather forecast. I will tell again, and we will discuss this again, but obviously the forecast doesn't give anything about the fact that I predict its path. If I predict that there will be a devastating pandemic in Boston in 10 days, well, people will behave differently. And then obviously the model have to take this into account. In addition, there are things that we will never have in real time. For instance, I can have all the vaccine stockpile in the world, and I would even be able perhaps to say, okay, in 1 week I can distribute to the entire population the vaccine. But there is something that I will never be able to evaluate beforehand. That is, how many people really will show up and get the vaccine. And so this is where, there are differences that I will discuss. And then also the lack of mindset. I don't know, and this is for mysterious reasons. No, not for mysterious reasons, but I don't want to say which reasons are. If you are in the weather forecast areas, in engineering, etc., the fact that you use quantitative generative models, computational methodologies, etc., is very welcome. And everybody will tend to say, okay, this is a good tool, and they know how to handle those. When you're in public health, this is not the case. And generally, you have a lot of skepticism that is also very good, actually, and obviously there are good reasons for that skepticism that I will try to discuss. But in general, there is a kind of lack of mindset. There is no what they call the man in the middle that has to talk, somebody who is able to translate the public health needs and questions into something that is digestible from a computational modeler and vice versa. And this is an important role that actually, well, now, for instance, there is an initiative from the President's office to create those kind of positions, etc., but it's not something that there are too many people with that expertise. Well, when we are going to talk about contagion processes, and then I can generalize not just to infectious diseases, to many other things, but infectious diseases is easy to understand. Well, networks and data are central. Networks is because our contacts, the way that I've been in a meeting with Carmen and we have been talking for half an hour together, means that if I am a carrier of a disease, she has been exposed and potentially she can get the disease. And so it's one link of a network. And then during the day, I have different links. And this is, for instance, is an experiment made with little RFID tag that measure face-to-face interaction on a 10-second scale that is made in a school, first, second, third, fourth, and fifth grade. And you see all the kids, how they talk and how they meet each other. You have seen, for instance, these are, for instance, recess time when everybody's talking with everybody. Then things goes down into each specific class. There is, lunch time, and you can evaluate all the interactions. This is a very complicated time-varying networks. Then we have all the networks that you were watching here at the center. That is, for instance, the international travel of people. The fact that you jump on a plane and from New York you can carry a disease to Hong Kong or vice versa. And then, obviously, there is a lot about our structures, social structure, communities, hubs, clustering. Clustering is that basically your friends are also friends among themselves, etc., etc. All those things that are important in the spreading of and contagion phenomena. Well, this is what was not available for a long time. And now you see that we start to have a lot of those data. And so this is what we started 10 years ago. We did start to build this computational platform that integrates data, various layers. The first one is the population data. So we need to have very accurate socio-demographic data. How many people are in each place? What is the healthcare systems there, etc., etc. Then you need to connect those people. We will travel. We don't just travel, we commute, we jump on a plane, etc., etc. You create a synthetic world that basically moves, in our simulation now we take into account about 6.7 billion people, that goes day by day as usual, And then on top of this network, we put a disease, a few infectious individuals, and then a dynamic for the disease transmission. So where it happens, in the hospital, in the household, etc., etc. And how things could go across the world. At this point, we can track the when, how, and how much, in a sense, of each disease, and try to understand how to say, the unfolding pattern of major epidemics, both in terms of incidence or prevalence in each place, but as well as, what is the probability to observe index cases by a certain date, etc., etc. And I will give you an example of that. Well, what is in this approach? Well, this approach has a set of inputs, what we call the hard part of it. So that means demographic data, mobility data. This platform is latched to the International Aviation Association and OAG schedule database for flights all over the world, commuting patterns, etc., etc. Demographic is from the Landscan project that from satellite imagery can get population densities. And then obviously an epidemic model. The epidemic model, there is no model that fits all diseases. Each disease has its own model, its natural history. The flu has a certain structure, Ebola has another structure, and so on and so forth. Well, you feed those data to a model that really simulates individuals traveling and meeting and transmitting the disease to each other in those different settings. And there is always two components. One is the intra-population transmission. So we indexes about 4,600 census areas in the world, and what happens to the epidemics within those census areas. And that depends on many things, the disease structure, but also the age structure and other determinants of the population, including healthcare system and so on and so forth. The response strategies. In the United States, you might have vaccines that are not available in West Africa or vice versa, I don't know, whatever, but so that has to be modeled place by place. And then there is an interpopulation mobility. You have an epidemic of Ebola in West Africa, how people will travel perhaps to other places in nearby countries, or perhaps they will be on a plane directed to the United States as it has happened. And that's at the end of this process that we do on a time scale of 1 day. This is the minimal time scale of analysis. Then you have an output. That is the classic things, you know. You can have maps with the incidence of a certain disease. You can look at probability or histograms of the number of cases that you will observe, and many other information you can ask to the model. Well, let me tell you something that beyond under the hood, well, the model is monster set of those equations, basically. So you have about 100,000 or more stochastic discrete equations that will couple those regions in the world. We consider what happens within each census area. And you can, you know, as a kind of naive picture, you can see something like that. Each of these areas are populations in the world, and then you have mobility, people moving from one place to another that might be infected or not, have different tags depending on where they are with respect to the disease, as well as other attributes of each single individual. And all that is done by the computer. Well, this is stochastic, and this is important to keep in mind. An epidemic with the same initial condition, the same parameters in the same population, might have different trajectories just because of chance. You know, the fact that I will be for 1 hour with Carmen in a room doesn't mean that Carmen will be infected 100%. There is a probability of this infection that depends on things that we will never be able to describe. I sneezed at the very time we were meeting, or perhaps, you know, actually, I was having another meeting with Ellen, and we shake hands, and she was the carrier of the disease, and I don't get the disease, but I pass to Carmen. You know, so this is chance. But the chance that is included in the equation will give, for each way that we integrate the model in the computer, a different trajectory. Obviously, those trajectories are not completely unrelated or crazy. They are related, but there is a lot of noise, uncertainty. So you have to describe this then at the end in statistical pattern. So what you have to do, and that's another issue where computation and computing becomes very important, is that you have to do millions of those simulations and extract the relevant statistical patterns. If you just look at one, very likely you are not getting something that is typical for the system. And the other things that is important to keep in mind is that we transform everything generally in those plots, which are maps, because in a cognitive way for us it's easier to understand what we're talking about. But the techniques that you use have basically nothing to do with the geography. So the geography is not relevant. It's very, you know, what is important actually is a distance that is not defined by kilometers, but is defined by people that visit the places, by our interactions. The geography may be important for certain diseases like the flu that has a seasonal driving, for certain vector-borne diseases like obviously malaria or chikungunya, where, you know, the vectors has to have certain, you know, you will not find chikungunya here during the winter because mosquitoes have a very hard life during the winter, you know. But this is where you can start to have attributes for each of these nodes. But basically, this is an algorithm that works on a very big networks of networks, and that's how it is in the computer. Then we transform that in images and geographical location because it's our way to understand what's going on. Well, the network actually is at all levels because you have the network of people traveling from one place to another. But then what we do when we really zoom in into the process is to say, okay, let's look at the synthetic population in one specific place. What is a synthetic population? Well, I get from the census data the households in that place. Obviously, I don't give name to people. Don't imagine that we are the Big Brother, so we are not going to have, but we have typical households that are statistically equivalent to the reality. So we have, you know, 2 adults and 2 kids, and then we have the age, and we do that with there are techniques to construct those synthetic populations so that at the end they are statistically equivalent to the real one, even in their geographic location. That actually can be now done with almost infinite precision because you can go through Google Maps and count, as we did for Ebola, villages, and you know how many houses in each village are from satellite image. then you know that those people will go to school, will go to a workplace, and so on and so forth. And what you do is that you create those bipartite networks in which those kids are going to school where is going this teacher, and these kids is from another household, and so on and so forth. At the end, again, you do a unipartite projection of those networks, and you get all the connection among individuals with a specific, you see this color, that this is telling you that this interaction is in a school, and it has a certain force or strength of infection. This is within the household, and so on and so forth. Now, just imagine this for 60, 100, 300 million people. These are huge networks that you use to understand the disease evolution. Well, what you do with that, and this is where I get into the case study. Well, this is Ebola, and you probably don't remember at the very beginning. It has appeared in February, March. There were a few cases in Guinea, and then a few cases in Liberia and Sierra Leone. Things were not clear. Things at a certain point started to decrease in Guinea. Yeah, okay, it's under control as usual, etc., etc. Then at a certain point in July, the disease appeared in the major capitals of those three countries and started to have an exponential increase in the number of cases. You know what is the story. It's a disease that is in a zoonotic reservoir with transmissibility through bodily fluids. So that's thing. And you want to understand now at this point what happens, how much we have to worry about it. And this is what policymakers want. This is what generally is asked to you when there is a new epidemic. First of all, you want to understand this simulation and create models that project the evolution of the disease worldwide. You want to assess the pandemic potential of a new disease. So it has spread from rural areas in West Africa to the major cities of West Africa. Is going to be in the United States, Europe, and other places or not? And this is the first question. Then the second question is the classic forecast, as you have seen for weather forecast. People would like to have those forecasts. So how many cases I will see the next week? 2 weeks, 3 weeks, 4 weeks, 6 months? The question is always when the epidemic will finish, those kind of things. And unfortunately, when you start to do those things, you are in one of the worst situations because you are always in what we call the fog of war. So reporting from the field is generally spotty, with underreporting, you don't know case history, you don't have patient line databases, etc., etc. In addition, you get a delay, a strong delay. Perhaps you get the data of 2 weeks before, and then you have to work always with this kind of, old picture of what's happening. But what is, I always say, there are worse situations. For instance, a worse situation would be a new disease that we have never seen. I'm not sure if do you know that there is now in the Middle East a disease that is called the Middle East Respiratory Syndrome, MERS. Is a coronavirus family disease. It's at the moment it has a zoonotic reservoir probably in Canada, though it's not 100% sure, and there is very limited human-to-human transmission. So generally we have nosocomial outbreaks. But if it would jump in the population, we would not know almost anything about the disease, what would be the reproductive number, the settings for transmission, etc., etc. For Ebola, it was not like that. Luckily enough, or unluckily enough, it is a disease that is plaguing us since a long time. And so we knew that the transmission was through bodily fluids, that the transmission was happening mainly in households or hospitals because of mishandling of cases, and that actually if you do isolation of cases right on time, the disease can be stopped. The other things that was good is that actually there were a few candidate vaccines available, and now indeed there is a working vaccine. But then we also knew a lot about the disease dynamic. How long was the incubation? for instance, the time from onset to hospitalization of cases on average. So all things that you can introduce in the model, and this is a starting point. It's not a given that the disease will have exactly those parameters, but generally a disease that doesn't change completely its structure, has very crazy mutation, keeps those parameters in a certain range that is close to what you have observed in previous outbreaks. And then we had a lot of data on international mobility, demographic data, hospital data, that 10 years ago we would have not even able to, I would say, to think of having. Just let me give you an example. We had a problem of mapping where the hospitals were in Sierra Leone, in those places. And you say, well, there would be an index for hospitals. Obviously, no. In those countries, no. Luckily enough, it's not a lot. Unlikely, it's not a lot of hospitals. We are talking about 20 hospitals, 30 hospitals, and then clinics mostly. And you say, how you get those data? Obviously, if you call people on the field, they laugh at you. They are fighting against, life or death for themselves and the others. You cannot have those data. However, you go and you know that there is a project that is called OpenStreetMaps, in which people plug from cellular telephones, etc., addresses of places and location with the GPS, etc. Well, you go on health on those places and you find the addresses of the hospital. So these are large collaborative things. Then you look at the Google images, etc., etc. So all things that allowed us in 4 weeks to have an idea very precise of where all the hospital facilities were in the country. And that 10 years ago it would have been impossible. Now, if you look now, there are maps that goes village by village in West Africa. So all people were going, with their telephone, getting data. What is the GPS here? Okay, then they were creating those maps, and now it's unbelievable. So, well, what do you do in this case? There is one problem. As I say, there is no model that fits all diseases. You need to define now the specific parameters for the disease in that place. A few parameters comes from previous outbreak, but for instance, the transmissibility of a disease depends a lot on social behavioral context. The fact that we need a lot is one thing. If we have burial procedure of some kind, it's a different thing. If the hospital is managed like in the US or in West Africa, it makes a big difference, and so on and so forth. So how you parameterize the model? Well, you parameterize the model by looking at the data that you get from the field. And you have to use several statistical techniques which are rather, I would say, elaborate, because these are models that generate millions of configurations of realizations. Then you have to take the mean. And what you do is a Latin hypercube sampling of the space of parameters. And then you compare the trajectory of epidemics that you get from sampling this modeling space with the real data points. And by doing MCMC, Markov chain, Monte Carlo, or likelihood analysis, you get an idea of what is the space of parameters you have to focus on. And that is the starting point that you can use to project what will happen in the future. Because now you have the parameters, you can feed the models with the parameters, and instead of looking at the past data, you start to look at the future. This is where you need the big supercomputing centers, because this is where you need to generate millions of simulations for billions of individuals and do that in real time. And that's still a challenge that, because generally, the use of supercomputing in this context opens several issues of technically for the computer science. Well, what do you do? When you do that, for instance, the first things that you get is a map with the past points. So this was our first calibration, and then you start to have to predict the next points. Then you have another batch of data, and you do the next prediction, and so on and so forth. This is where you see that prediction might be useful. And forecast, I always say, for diseases is like for weather. You cannot forecast in six months from now. Because I don't know what will happen 6 months from now. The United States have brought there the one-on-one airborne division. And obviously, this has to be factored in the model somewhere that you build, 150 water treatment units in 3 weeks. But I don't know when it happens. So it's important to keep this model as something that every week or couple of weeks you redo your predictions. But you see, initially, what was the problem is that the things were on this trajectory. This is a log linear scale, so this is an exponential increase. And you see that all the points were aligned on this exponential increase for almost, 1 month. And it was the bad news. That is where, everybody started to be alerted and say, okay, we need to do something, because an exponential increase with a doubling time of 3 weeks, 2 to 3 weeks, it's going to explode in a few months. And this is where what you can do now a posteriori. You see, this is a tool that we have in which we do this 4 points prediction, and that is for the Sierra Leone, I think, and this was for the whole area. You see immediately that there are corrections. You have to adjust your prediction. For instance, here we were overshooting in the West Africa as a whole, and this is because our last batch of prediction, while the U.S. Army was building those infrastructure and capabilities there in place, and we didn't have news about that. And the United States Army too was not able to say when things will be ready, etc., etc. So at a certain point you say, okay, it has opened this facility, and then you can start to correct things, and you have those issues. And here is the problem I was telling before. We can do this exercise many times. It's great, it's good, but we need to keep into account this. So we have information on a disease. So you project that it's exponentially increasing. And this is not like the hurricane that will continue its trajectory. People will do things. And so you have to include in the modeling the fact that people will do things. Behavior, and could be even self-initiated behavioral changes, or the fact that you bring there healthcare workers, facilities, you deploy on the ground the safe burial teams that were going around houses to bury properly the victims, etc., etc. These affect the disease progression, that will affect the information, and so on and so forth. And this is the difficult part of this game, because in many cases, that opens the skepticism of public health, because people say, okay, but you were predicting this big mess, and this big mess didn't happen. Well, obviously, it didn't happen because since you know that there was going to be a big mess, you did things on the field. And so that's the use that you have to do. Now, during all this, the period of Ebola, you might remember that certain point the CDC put out a paper in which they were projecting, I think, 1.5 million cases. It was the end of the World Pandemic. And obviously, this is true if you continue on that exponential trajectory for many months. They had really what I call, a problem with on how they broadcasted that to the media. Because on page 2 of the paper that was saying, okay, but this is the worst case scenario. We are going to look at something different if we do this intervention and that intervention. But everybody picked up just that message. And so this is because forecast, like for weather, you cannot push too much in advance. 2, 3, 4 weeks is what you can do. Then your analysis becomes a scenario analysis, in which you can project what will happen if things are deployed on the field or not, if you are effective or not, etc., etc. At that point, you can start to say, okay, this is the worst case scenario, but then you have the good case scenario. Then obviously, the communication of all that, also to the public health officials as well as media, etc., is complicated. It's not trivial. But then the thing is that computational modeling is more than forecasts, and that is what I think is an important point. And first of all, it's a situational awareness tool. It is an intervention planning tool. Provides projections. So what we were discussing a few seconds ago. Provides epidemiological explanations and structured reasoning. So this is something that we have written with the Myers group in a paper published on the Proceeding of the National Academy, where this is really just a good read if you don't want technical details. It's just a discussion of how you can use modeling. Let me give you a few examples. This is situational awareness. For instance, I can use a model to project the exponential increase. But then I can use a model in which I assume marginal containment for the disease. So the disease is more or less contained, although you still continue to see cases at a low rate. Or you can have the full containment. The disease is going down and you are bringing the epidemic into the end game. And you see that you have those projections, and then you can look at the real point, and immediately you get a sense of what's happening on the field. Obviously, after early September, things deviated consistently from the exponential growth. So it was not that. It was closer to the marginal containment, but by I would say probably mid-October, it was clear to everybody that we were in a containment scenario. And so this is important situational awareness that when you look just at the report on the ground, you cannot get. You get that you still perhaps have 100 cases per week. And this seems a big number. But then you say, look, this is what would happen if we want to be in the containment. It will still increase, but that is the rate of increase that is important. The other thing is how you can do intervention and planning. Well, this is something that we need to understand the pandemic potential of the epidemic. So what you do? Well, you have this global model. You have the evolution of the epidemic in West Africa, and then the people travel on the plane and they go into countries. We were looking every 4 weeks at what was the probability of importing one case in another country. Well, we monitor 220 countries. We didn't report what happens for the 220 countries because it was irrelevant, but this was the top 20 at risk. And the different colors are different models in which you imagine to have border screening at the origin or at the arrival destination, etc., etc. But you see immediately that you get a list of countries that should be under a kind of close scrutiny, where you want to discuss what to do in terms of border control, etc., etc. Although, one important message of this figure is that even by end of August and then October, the probability for most of the countries were of the order of a few percent, 10%, 15%. So obviously you can see somebody there. But you might have one case. This, let me tell you that then this is the first projection. Then we went to another projection every 2 weeks. So our top countries were Ghana, United Kingdom, then United States, Gambia, and France, Senegal. Most of the countries were affected by the epidemic during the day. So now the problem is that I realized when we were doing this that I was doing, while communicating to policymakers, this is considered very useful. For the media, that was something that has been manipulated in all possible ways. And you say, why is this possible? Because people were associating to the 10% probability or the 20% probability, not the fact that you can get 1 or 2 cases, but the fact that this was like opening a door, and then suddenly you will find thousands of cases. And obviously it was not like that. And then you have to study how to communicate people. Yeah, you have to communicate more basic things. So maybe what is the probability of observing 1 case, 2 cases, 3 cases? Then it becomes more clear that in September the probability worldwide to have 2 or 3 cases around the world was a few percent. Mostly you were looking at 1 case. And then you can do the various scenarios, the containment, etc., go for single countries and so on and so forth. So this, for instance, is important as a message because the point was, okay, September, October, we were looking at a handful of cases, as it has been. And obviously in the Western world, that was all the countries were in that list, roughly, we should have been able to contain those cases. And what was important instead was to keep working on West Africa. We wanted to, to extinguish the fire there. Because if we were not able to do that, then you see that the number starts daily to blow up. While you see that as soon as you get into the marginal containment, those numbers remains 1 or 2 cases, and every decent healthcare system should be able to face this, and then actually in the case of containment, this probability is negligible even for 1 case. So, but this is another way in which you use modeling to create planning, to decide what to do. Do we close border or not? It's useful at this stage or not, because closing border, unfortunately, has a lot of issues in the way you deliver the help on the ground. So, you know, there are many things that that you can somehow discuss from okay, I'm getting late. This is traffic restriction again. Let me also tell you something. That is a clear example of how modeling can restructure thinking. It's because those models are highly nonlinear. And so our regular linear thinking doesn't work very well. One thing is that, let's imagine that we have in a subpopulation the epidemic. If nobody travels, obviously the epidemic will be contained there. It cannot go out. People will not travel, will be, you know, in that village or that city will be strongly affected, but there will be no global epidemic. Now let's imagine instead that each individual in the world every day jumps on a plane and goes somewhere else, randomly. At this point, it's like if you have a huge population that is deeply interconnected, there is no distinction of each subpopulation. At that point, the epidemics will obviously get global. Well, there is a critical point in beyond that tells us that actually the time that you spare in terms of epidemic evolution goes like the logarithm of the traffic restriction that you apply. Well, now you know that the logarithm is a very slow quantity. So if you change by 1 order of magnitude, you get a proportional factor. But if you go from 50% to 80%, this is not a change that really is of an order of magnitude. You might gain 1 week or 2 weeks. And that's one of the reasons why border control is generally not the suggested measure, unless it's something that is so lethal and so disruptive that then really you want to close completely the border. Because as soon as you leave permeability, this nonlinear factor is making the difference. Well, and then you can do a lot of epidemiological explanations. For instance, in model, you can create models in which you look at how the transmission goes into households, hospital, and funeral, compared with the data. You can get what will happen with respect to the underreporting. The blue curve is the curve in which we assume that the underreporting was about 100%, because at a certain point we were telling, on the field there are twice the cases that are reported. And you can say, no, look, this is not feasible. This cannot, we were not able to fit any model to that underreporting. Indeed, the underreporting was about 20%. So you see that you get epidemiological explanations, and you get also kind of counterfactual things. For instance, you can do subtraction to the model and say, what is the important component for the transmission? The fact that I go to the market and travel, or just the fact that I spread the disease in the household, and then from time to time I have to seek for an hospital that is, I'm seeking an hospital that might be many miles away from my place in those areas. Well, you can do the full model and see certain things, but then you shut down everything and just keep the household mobility, so that you ask for your parents when you have somebody sick at home, and then you look for hospitals around the country. And those kind of mobility are enough to describe in an accurate way all the geographical expansion of the epidemic. And so this is a way in which you do somehow some kind of structured reasoning for the model. So you say, okay, I can take one piece out and look at what are the relevant pieces for the transmission that are able in the model to recreate what I see in the reality. And that's very important to understand what are the main drivers of the epidemics that you might not see in a transparent way by looking at the reality of the data, the complex reality of the data you get. Another thing is that you can do experiments like, okay, how many cases I have averted by each of the interventions that I have done? Well, this is very difficult to do from the data. You just get, okay, I built these 2 Ebola treatment units, I did the safe burial teams deployed, I got the safe burial teams deployed on the ground, but I cannot disentangle things. Well, in a model I can do, I run the model with all the intervention that has been used, and then I switch the intervention one by one and say, okay, if I don't do the ATU, I get 15,000 cases on average more. So mostly the ATU were able to avert, 15,000 cases. The safe burials along with them, 24,000. Then at a certain point, they started to distribute protection kits at home that were reducing the transmissibility in the household. Well, you see that if they distribute 50% kits to 50% of the households, you get another 6,000 cases averted. But then you really, at a certain point, you break, you go, that kind of, it's not useful enough. If you do a 90% coverage, you just gain 2,000 cases at a cost that is immense, because you have to bring, this in remote regions of Liberia. And so you start also to get information like, okay, I can stop, there is a kind of tipping point below which is not, in terms of resources convenient. There is just a marginal benefit that is not enough convenient in terms of resources. And that's also is something that comes from the model as structured reasoning, so in killing various components. And so I'm closing here, just to tell you, although it's not, that modeling is, is important not despite the lack of data. This is my way to say so, but actually precisely because of the lack of data in some cases. Because, you will never have a full picture of what is happening on the ground, but you will have enough data for the model to be accurate enough. And at that point, you can look at different part of the model to see what really was efficient, was effective, what was irrelevant, and so on and so forth. And you won't get that because of the lack of data from just simple statistical analysis. And so that's one of, for me, my main message. Obviously, along with the forecast, but there are many, many other things that you can consider. Last two things. Obviously, social behavioral changes is the next frontier. We need to understand better how we behave for modeling and how communities behave, etc., how we can act on communities. And then the other things is the interdisciplinary partnership. There is no way to say this is a computational effort or a public health effort, so everybody's involved. In my group, I have an economist, I have a biostatistician, some computer scientist, a physicist. You really need to have all people getting together, and this is for most of the group that works in the area. And I think this is where I'm very happy to be a Northeastern, because there is a culture that is really bringing together many, many different expertise, programs, and so on and so forth. Thank you very much. Questions?
I have two interrelated questions. First of all, thank you so much. It was a really helpful talk.
Thank you.
My main question has to be, if you do have 40,000, 100,000 different equations, at what level of your network do you start worrying about over-specifying, the lack of generalizability? And then secondly, I see you're looking at model fit by geographic location, but sometimes there's perhaps an overall model structure that might not fit. How do you handle this in a principled way?
I'm very conservative on that, and I totally agree. One of the worst things that you can do is to use agent-based model with 20 parameters. Originally, many years ago, I was a physicist, and we say, with 3 parameters, you fit whatever you want. With 4, also the moving of the tail of the elephant, whatever. So if you have 20 parameters, you can do whatever you want. The model that I've shown to you, most of the data is hardwired data from the field, so there is no latitude on those. I had 3 parameters in the model that I've shown to you, just 3, that were the 3 transmission settings. And that's, you can do, you can be reasonable that you are not overfitting. That is always the delicate balance. Then, initially, the first model that I've shown to you, the one for the pandemic things, was a model that was much less accurate at the macroscopic level. We didn't have the houses, etc., because I didn't have the data. So you need also to, the more you are complex, the more you need to have the hard data in. Otherwise, so let's start simple. The first days, you can do even the simple SIR model that we know from all the textbooks. It's fine. You know, then the more you get data, now we can get much more data, but never go into something that is completely not transparent, because obviously if you have 10 parameters or so, it's you can do everything. So, yeah.
So a complement of that question is you're using to the need for behavioral modeling, because right now you probably modeling the like I'm not up to date on this, but you're probably modeling the transmissibility by a coefficient, by a probability, right? But that is affected by behavior. Now on our end, we are trying to stop obesity epidemic, and we have to actually address individuals and try to model their behaviors. I think it's possible now to develop models which will predict how behavior will change with different interventions. What do you think?
I think that this is the way to go. This is the research, and I do a lot of things which are not related to infectious diseases, but are related to spread of information, contagion, smoking habits, and things like that. I don't want to give this kind of talk with those examples because it's a little bit more complicated, and I don't sort of want to look like a crackpot saying that okay, you can turn angles here and there and get the solution for everything. It's not like that. Also because the data we integrate here might be completely irrelevant for smoking addiction, or even, for instance, there is another infectious disease that is DPC. You know, it's a big problem now. But you don't need a one-day resolution because this is a disease that has a very slow spread, and you don't need the airline movement or commuting. What you really need is to get the migratory pattern of people, immigrations, etc., etc. So you use different data, different time scale, but then the framework becomes very similar. For smoking addiction and other things, it might be the same. The social behavior is crucial, you know, and I won't go in that direction. For the diseases, it's, yeah, you know, there are things that you can do and things that you cannot do. For instance, fear is something that spreads in those kind of diseases independently in a completely rational way. It's very difficult to imagine intervention, although we all try. In West Africa, we had cultural problems. You know, many people were not trusting Western medicine, so they were going to the village doctor, and that was a big problem, and things like that. And then you can try to do interventions. At that point, for infectious disease on this time scale, those interventions, yeah.
But the weather prediction was really benefited a great deal when data assimilation was introduced, when we combined the physics model with the principle-based model with the data from the only stations coming in, right?
But, you know, for instance, one of the things, and I'm thinking about the use of mobile phones into communicative behavior. Those are regions that, although you say, well, the healthcare system is behind, etc., etc. Now, almost everybody, or at least the household or the village, has a mobile phone, and you can communicate with that. And the effort was not in place for this case, but one can imagine to send a message to have reporting from the ground. They use the telephone mostly as a currency, so you can give credit on the card, and they can trade those credits. So, you know, there are a lot of ways to act. And you say, well, but these are very expensive things. Yes, it's expensive, but even sending, you know, what we have sent there was 50 billion. So these are amounts of resources that are so big that you can imagine to start testing intervention as well as real-time monitoring, and that would be very, very important. And those are regions that in 10 years will be with a completely different infrastructures in terms of communication. Yes.
So I was going to ask like sort of the parameter question too. How many parameters are really in the model? So as you say, 3. So I'm trying to get my head around what are the 3 parameters? Because you're mentioning a lot of things that could impact this. I'm wondering how those end up in 3 parameters.
Well, you know, for instance, I was telling about the safe burial teams. The safe burial teams, I had the timeline of all the interventions that has been done and the teams deployed on the field, and you can basically get that from data. When you project in advance, you keep that level constant in a sense. So you imagine that. For instance, hospitals, we were having all the positions of hospitals, the number of healthcare workers, where the healthcare workers were, and the pipeline adopted in the hospitals. Initially, unfortunately, people were kept in holding centers. That is the worst thing you can do. Basically, you have the flu or the malaria, you go there, and then you spend 3 days with somebody else in Goa. And that's indeed was the big bust initially. And then they adopted a pipeline from a certain day and was implemented on the times of 2 weeks. So all those are there. I would say the villages, the household structure, etc. Then what we didn't have was really within the households. If you want to it's a little bit more complex, but it's really the probability I was talking before about what is the probability that if I spend 8 hours with Carmen, she would be sick. That's something that nobody can tell. And the model needs that. I need a probability of infection. And that is something that you find, and the same is in a hospital setting, and the same is during the safe period. So the body is on average, each diseased person was for 2 days into these burial practices, and you have to imagine what is the probability that a body will transmit to other people. And those 3 parameters were not known, and they are still unknown in a sense. Also because of parameters that depends on the model structure that you use. This is not it's not that they exist this code. And so these are the 3 parameters where we did the calibration using those techniques like MCMC, etc., by using 2 main data. One was the daily cases, the daily new cases, and the second was the daily new cases among the healthcare workers. And then the same for fatalities. So these are time series that allows you to get the MCMC, and you check all the peaks, convergence, posterior distribution, etc. We have introduced now in a new paper, that a new work that we have on DNE, a 4 parameters that is really something that that relates also what happens in the more general community, but because now we have more data, and so we are more confident that we can, in a sense, expand things. But this is initially what we are. So most of the other things are really hardwired. Then you may have things like there are still a few parameters that you know that they will they could vary. For instance, the number of what we call the extended household is another important data. So your household is one thing, and then you have your parents' household, your friends, etc. These generally changes village, could change village by village, and the distance to, etc., etc. In those cases, what you do is that obviously you can have an extended household made of 3 other households, or 4 or 5, not 50 almost. So in those cases, you do sensitivity analysis. And you say, okay, I did all the things with 2 households, then I do with 3, and then I do with 5. And then you see how much the data changes. If the data doesn't change less than that 10%, you say, okay, that's what I more or less have been told by the census or the demographic, and then I imagine that there is some level of adjustment that can be tolerated by me. And this is another important part, is the sensitivity analysis. So all the hard data that you get, you know that they might have a little bit of uncertainty or error, and then you have to check the stability of the model with respect to the parameters. So if you change a little bit those parameters, if the model falls down, it's something completely different, and it's a problem.
So,
Yeah.
could you adapt the model to look at teen pregnancy or STIs within a urban area? And if so, what kind of parameters would you need?
Okay, so STD and TBC and TB
No, STIs in pregnancy.
and pregnancy.
Teen pregnancy.
Then I need all. That is you get. This is paradoxical, because I started with using network things for HIV, and so that was my starting point.
Okay.
It is impossible to get the data.
it's impossible.
Yeah, it's you know, that is where all the issues about privacy comes in. So it's what I need is who you were sleeping with in the last
So that you
years,
don't get
and
subjected.
that is always a little uncomfortable.
But if
I got those data. So I got
Yeah.
data from Sweden, from UK, even from US. But you get data which are not usable for detailed modeling. Can give you an idea. So I was getting how many sexual intercourse you had in the past 3 months, 8 months, and I think for Sweden lifetime. But I didn't get the name of the people, so I could not create the network. I knew that somebody was a super spreader, so I had, you know, the thing was crazy because there is this very long tail distribution. Some people have 300 partners in their life, or, you know, there is in the US, you see this, what they call the Friday bar peak, so that, yeah, there is people that has one different partner per week, and that's not because they are sexual workers are always kept outside. So basically they hang out in the bar and then you have sexual intercourse, a person that you will never see again. And generally the question there is that, can you tell who was that person? And the answer is always no, I don't remember. So, you know, it's even that, and they need that network. If you go at the level of family, if we would need to set up a big project, like getting a community,
right,
and set up a 3-month studies in which you get everything very, very secured on a specific database. You ask people who they would, and you construct the entire network. If I have that network, then I can do it. So this would be fantastic. We have been, you know,
because I'm just thinking about in urban areas where the networks are very intertwined.
Yeah.
That, and it's a very small but dense area.
Yeah.
That if we could show communities and predict over time, it might be able to change behavior, both for teen pregnancy and for STIs.
if you have the data, I would be willing to go into that. My problem was always
So you can't use census data?
I can use census data to recreate. So if I get data from a sample that is even anonymized, I could try to get the synthetic version, so the one that is statistically equivalent, but is not the same.
Same, okay.
Because I cannot anyway show a simulation in which there is Joe, Andy, and Lisa. I need to have something that is statistically mixed, but I need to know what is the real network to know. Also because there is an issue with the sexual relation, with the sexual intercourse, there is the concurrency issue, and I need the time ordering of the relations, and that's very important.
And
Why?
safety, whether they're using condoms or not.
If they're using well, and then there is the risk of that connection, and so, you know, I need all that information. Otherwise, I can do global models, but it's less adapted to the single community.
Okay,
Yeah.
thank you.
Yes.
I have a question about, I know Ebola kind of came up and it was a very urgent matter, and I was just curious how long it took for you to get the model to forecast.
It took us 3 weeks to get to pull out the first forecast. And then from there, it's a matter of improving and getting more. So as I was telling, the first model was less detailed, and then we went into specific countries. Now we have been working about the vaccine trials, and that is another layer of data. However, that was one of my lessons, and it's a lesson that I'm trying to tell everybody, because we get a lot of funding and support and enthusiasm for those techniques, but we always get to say, okay, let's prepare for the United States, for UK, for Europe, for Italy, for this and that. If I tell, okay, look, I'm going to focus on Central Africa, in creating those synthetic population. Each synthetic population is a month of work. And then you don't get the funding, etc. While basically we would have spared more than 1 month if we would have prior work done in that region. And that's something that is very important. I'm advocating with your agencies. Also for our own sake. You know, the next emerging diseases will not be here very long. It will be in those places. But if every time I need to go through the process I went through for West Africa. It's 1 month or more, perhaps. It depends on cases of overdose. While if one could get those data much earlier, it's done. So unfortunately, this is the thing, is that how you get that done. It's really, synthetic population is 1 month of work of 3-4 people working full time. There is a lot of, that's the other problem of, it's there, not parameters, there are data, but they have to be manually curated. There is no the database where you magically download that. So,
You mentioned that you actually counted them, the vision and how
yeah,
it's.
yeah, you are really good.
Okay, thank you so much.
Thank you.
Christine, yes, thank you.
Thank you. I would say thank you so much. That was a great talk. We really appreciate you coming. Tell by the questions that people are very excited about it.
Yeah, please.
Some of the not really hard.